morning from Miami Beach. It's Dr. John Bennett for Neurosurgical TV. I have the pleasure of hosting the Juha's Neurosurgery Grand Rounds from China. I'm going to turn it over to Warlix to introduce Juha. Hi, Warlix.
Hi, John. Hi, everybody. Welcome to Neurosurgical TV as usual. So today we have a really amazing topic again that bring by Professor Juha. So let's move on to Dr. Juha to introduce Dr. Lanzino. Please, Dr. Juha.
Hello, everybody. Best greetings from China, Chengzhou. So I speak about introduce my old friend, Guiseppe Lanzino, like the name says. And it was discussed, he's coming originally from Italy, but working in USA since many years. He's one of the most creative, productive, and critical hybrid cerebrovascular neurosurgeons in the world. Certainly, this is true. His works at Mayo Clinic in Rochester, Minnesota, with long time experience as #1 institute, of course, is getting very difficult cases to be treated. Some years ago, he celebrated his number 500 publication. I don't know exactly what is the number now. It might be even 600, but anyhow, he's excellent in writing, doing scientific writing, but also giving regular speeches and lectures. But he's also good in treating the patients, and this is certainly true. We have been friends since close to 20 years. After his first visit in Helsinki, there have been bilateral visits. I have been in Mayo clinics, and we have met several times in Italy. He has been also here visiting Chengzhou, Henan Provincial People's Hospital, when I began my working period here. So it was great pleasure to have him here and to encourage in the beginning time here in China. To come to the topics, dural fistulas. Nowadays we are diagnosing increasing numbers, and of course every institute has by far more cases. My personal experience is 251 cases. This was published in the papers and PhD of Anna Piipo in Helsinki, 2013. These publications and experience remains a historical remnant because main part of the cases were treated by microneurosurgery. I asked today at Henan Provincial People's Hospital in my center, Dr. Bai, who is usually treating these cases. He told that he has 40 cases a year. Unfortunately, the statistics for the whole big, huge hospital are not known, but anyhow, we see at least one case a week, and they are mainly treated, as nowadays is the case, by endovascular means. So it is very important to have extremely good follow-up of these patients. This is my experience of my series, 251 cases. I saw 2 extreme examples. Here, this is a around 50 years old lady, had a rather not so complex dural fistula. It was treated several times by the best hands in the world, by Professor Moret in Helsinki, and every time a good solution was found and tried, and next year it looked even worse. The patient had headaches and never bled, but had very disabling headaches all the time. And every year, this dural fistula became worse. And finally, we stopped to try anything because we couldn't find any solution. Another case is this one. I treated mainly by microneurosurgery. Young female, 20 plus years, and in the same way, during the 5 years, she all the time developed, in spite of several craniotomies and endovascular treatments, all the time, new Dural AV fistulas. She had headaches and vision disturbances, but we couldn't find any solution to have final good treatment. So I think one of the most important things is extremely good follow-up of these cases. If you are happy with the first treatment solution, you should follow up these cases many years, because there seems to be few cases which are not obeying any our treatment commands. So this is just to tell importance of the follow-up. That is unfortunately not the best one in the big countries, especially in China. It is very difficult to follow up the cases. So if you are happy with your treatment results, you should have a long-term follow-up. And these examples show that you should not speak about your results if you have only 1 or 2 months follow-up. So let's give the word to Giuseppe Lanzino, who has certainly some new thoughts and critical thoughts of the treatment of dural AV fistulas. So please, Giuseppe, my good friend, go ahead.
Thank you, Juha, for the extremely kind introduction, and thank you so much for this invitation. Can you all see the screen?
Not yet, not yet.
Can you?
Not yet, not yet.
Not yet.
Okay, let me.
Thanks, Warlix.
Okay, we can see yours now.
Okay, good. So the topic is a topic of great interest to me, because it's really, as Professor Ernest Niemi mentioned, really the treatment of these lesions has changed over the past 20, 30 years. And it has become much more about the strategy rather than the treatment itself in a lot of these patients. This is a landmark paper from here, Mayo, and was in 1983. And at that time, really, surgery was the mainstay for a lot of these patients. And in this paper, in this series, there were patients that actually had a massive bleeding intraoperatively that was difficult to control. And things have changed to a great degree, because now we have a lot of options. We have embolization, stereotactic radiosurgery, surgery, and for some of these patients, observation alone is good enough. And when you have options, it's a great thing, but at the same time, you have to be careful not to be constrained by the choice of one option over the other. It's important to use the different options available, and you can really truly individualize the treatment. And as I start thinking about these lesions, I start thinking, well, it would be nice if we can achieve the ideal goal for any cerebrovascular disorder is to treat the problem with really no mortality and morbidity. So I start thinking, particularly with dura fistula, I think we are very close to that goal. Now, when we choose a treatment strategy, what are the factors that are important in our decision making? Well, symptoms of the patient. Nowadays, we tend to see more and more of these lesions that are found incidentally, which was something that was very rare in the past. The angioarchitecture, it's very important in understanding which technique is better. And then, of course, the location plays a major role. And location for dural fistula, it's often closely related to the angioarchitecture as well as to the symptoms. So when we choose a therapeutic modality, my considerations are, number one, I like to have a treatment that is safe, and then treatment that is effective, and then I consider how invasive is that treatment, and this is in order of importance. And there is no question that here, if you have a treatment that is safe enough and effective, from a patient perspective, there is more and more natural tendency to have to prefer a treatment modality that is not particularly invasive. So I thought that the topic is so complex, and almost every dura fistula, every single case, it's a little bit different for the other one. So I thought that in order to illustrate the thinking, which, as I said, it's really the most important part to achieve consistent success, I will show some case examples and discuss the strategy. And then along the way, provide what I would consider some pearls, that the practical pearls more than anything, things that I've learned or that I've heard from some colleagues or from my teachers, and that might not be immediately available in the literature and so forth. So first case, it's a patient that presents with hemorrhage. It's a 41-year-old, sudden onset of a headache, and then a decreased level of consciousness to a coma. Of course, in this case, the hemorrhage and requires immediate treatment. We did a CTA, and you can see on the CTA there is a varix that is along the petrous ridge, and this is a typical finding of the so-called lateral tentorial dural AV fistulas. And then as you follow the vein, you see the hemorrhage, and you continue to follow the vein, and this is eventually the drainage. It's a fistula with an exclusive retrograde venous drainage, and the draining vein eventually drains into the straight sinus. One important feature here, you can see here a venous varix, and this is the point of rupture, which will bring me to the first practical consideration, that in dural fistula, the point of rupture often is distant from the actual point, from the actual arteriovenous connection, from the actual point of fistulization. Here on the coronal, you see better the venous varix and the relationship of the venous varix with the hemorrhage. This patient was stabilized, and with external ventricular drainage regained the consciousness. An angiogram was done to better define the lesion, and you can see here the meningoepiphyseal trunk through the tentorial artery, draining, feeding this fistula, and you can identify the point of fistulization from the change of caliber. From the small arterial feeder, there is often a tiny little nidus that is within the dural leaflets. And that's another very important concept to understand, because the fact that the arteriovenous connection, it's at the level of the dura, allows us to treat these fistulas by closure of the proximal draining vein, because the actual point of dura of connection, it's within the leaflets of the dura. That is like almost like a carpet. And that's the reason why we can do that, as opposed to parenchymal arteriovenous malformation, where you cannot treat the fistula by primary closure of the draining vein, because you run the risk of promoting a massive explosion of the lesion. You can see here, as you follow the fistula, there is the varix, and this is a very unstable situation, because you can see that there is relative outflow stenosis. And in this patient, what I think it happened is that originally, you can see the fistula was drained by the superior petrosal venous system, and there are often two components, but you can see that the inferior component probably has undergone thrombosis, probably because of the high flow venopathy, and now the sole drainage is this vein that is the site of rupture. And another issue here that is very important, many of these lateral tentorial fistula are good for embolization, because they are fed by the milomeningeal artery. And the milomeningeal artery is the friend of the interventionalist, because it's a fairly straight vessel, and when it's feeding a dural fistula, it's often hypertrophic. So it's a relatively easy vessel to catheterize. In this particular patient, you see that the main supply of the fistula from the milomeningeal artery through the petrosal branch. And there are two issues. Number one, it's fairly tortuous at the origin, but more importantly, the petrosal branch also provides blood supply to the facial nerve. And here it's another important point, that even though this fistula potentially could have been a good target for embolization, in this particular patient, besides the hemorrhage, there is no reason really to put the facial nerve at any risk, because this is a relatively straightforward surgical target. So what are the considerations in this particular patient? As I said, number one is the issue of the hemorrhage. Number two, the feeders are relatively small and fairly tortuous. So the catheterization, it's difficult in the sense that it would be extremely difficult to get distal enough to be safely close enough to the actual point of fistula. And as I said before, the milomeningeal artery would be the preferred route from an endovascular route. But in this particular patient, you have the petrosal branch that also provides a blood supply to the facial nerve. So because of all these considerations, that is a type of fistula that nowadays we prefer to treat surgical. And you can see here the clip at the point of fistulization. And again, the key is the occlusion of the proximal draining vein for this dural fistula that have exclusive retrograde cortical venous drainage. So Again, to stress a practical point here is that in the case of dural AV fistula, like brain aneurysm, for example, the site of rupture, it's often distal from the actual point of the arteriovenous shunt. So something to keep in mind. And again, here, this is the point of shunt, but here is the point of rupture at the level of the venous varix. So as I said, that this will be a lateral, what we classify, and Mike Lawton also in his classification, as a lateral tentorial dural AV fistula. And this it's the most common type of dural fistula that we encounter. It does have exclusive retrograde venous drainage. Typically, when it involves the superior petrosal venous system, and therefore the location, as I will show, it's fairly typical and relatively consistent. This is another case. It's a 69-year-old presented with imbalance and dizziness for a year, and then for 6 months start having double vision. And this is the MRI in this patient, and you can see that there are dilated veins throughout the posterior fossa with a large varix, again along that seems to arise from a vein that takes off along the petrous ridge. This is the angiogram, and again you see a dilated, massively dilated, mostly petrosal branch of the milomeningeal artery, and then you see the largely dilated posterior fossa veins that drain in a retrograde fashion eventually to the transverse sigmoid sinus. Here, this illustrates another point, the practical point that is very important to consider, and that I will make later again, is that dural fistula, the dural fistulas that don't involve a large dural sinus, those dural fistula that have exclusive retrograde cortical venous drainage, those dural fistula might appear fairly complex on the first view of the angiogram, but once you can decompose the anatomy, then they become relatively simple to understand and to treat. This patient, the CT angiogram sequences have been very useful. You can see in identify the proximal draining vein emerging from the dura, the level of the petrous ridge. And this is a video so this is a retrosigmoid approach. And this is, as I said, is the level of the superior petrosal system, the junction of the petrous ridge with the tentorial. ICG fluorescent, it's useful because it will confirm, it will help you to confirm the anatomy, but also to confirm closure of the fistula. And you can see this is a typical appearance with all the dural vessel converging into this single draining vein, which eventually emerges from the dura. This is the two components of the draining vein in this patient. And as I said, treatment, it's fairly straightforward in this occlusion of the proximal portion of the draining vein. And this is the immediate post-op CTA. You can see the clip, and you can see the venous varix on the CT on the right that now has undergone thrombosis. This patient had been previously undergone an attempted embolization at the other institution. So you can see some of the onyx into one of the draining veins. And this, as you can see, on the left, it's the preoperative MRI. On the right is the follow-up after 3 months. And you can see the regression of the large draining veins with the thrombosed portion of the venous varix. This is another example of a lateral tentorial dural AV fistula, again to stress the fact that they have a fairly consistent and typical appearance, again supply from the meningoepiphyseal, from the tentorial branch of the meningoepiphyseal trunk, and also in this case from transosseous branch of the occipital artery. You can see this reconstruction of the CTAs are very helpful to confirm. And once again, a typical appearance. This is the tentorium. This is the petrous ridge, and you can see the large draining vein, all the dural vessels converging into the large arterialized draining vein. And again, fairly straightforward treatment. In this case, again, it would have been there was not a good embolization. There was not a good feeding artery that we felt would have allowed us to be distal enough to be effective. And of course, in this particular case, so there is the consideration that the surgical approach is fairly straightforward and safe once you identify the actual angioarchitecture of the fistula. This is a tentorial fistula, but this is a little bit unusual in that the actual draining vein is from the surface of the tentorium. It goes supratentorially. This patient presented, you can see, with the small parieto-occipital hemorrhage. This is a different situation. There is a good endovascular target through the middle meningeal artery. Here is the point of fistula. Here you can see the onyx cast. There are we were able to get distal enough with the microcatheter. You see the microcatheter is still here as we are injecting onyx. There are no dangerous anastomosis we need to be worried. And here you can see the distal microcatheter position, the onyx cast filling the proximal portion of the draining vein, which again, it's the critical point to achieve a cure. And this is the pre and the post-operative, the immediate post-procedural control. Now, on the same theme, again, the lateral tentorial dural AV fistula, a different patient to bring home the concept that, again, you cannot really generalize. And this particular patient, there is a lateral tentorial fistula. The main feeder is, again, the petrosal branch of the middle meningeal artery. But unlike the previous patients where the proximal portion was very tortuous and did not allow us to get distal enough to be safe, in these particular patients with the microcatheter, you can see we were actually able to go from the arterial side into the proximal draining vein. So we are very distal. And this patient that presented with facial pain and pulsatile tinnitus, you can see again the typical appearance of the arterialized draining vein along the petrous ridge with then retrograde involvement of posterior fossa veins. This is the angiogram. But in this patient, unlike the previous ones, despite is the petrosal branch of the middle meningeal artery, we were able to get all the way into the proximal venous pouch and safely able to fill it with onyx with resolution of the fistula. And as Professor Ernestiemi mentioned, it's important in this fistula, especially after embolization, it's important to have a distant follow-up because there might be not necessarily recanalization, but there might be what I think it's residual fistula after the embolization that it's not well seen on the immediate post-procedural angiogram, but becomes evident only at follow-up. Now, a practical point is that dural fistulas are also very interesting because really they can present with every single neurological symptom and signs known to medicine. So it is very important in some of the cases that might not be that clear to have a relatively low grade of suspicion, especially if you see otherwise unexplained changes on the flare MRI or any dilated vein. This is a 52-year-old with progressive cognitive impairment. And he underwent an MRI that raised a suspicion of an abnormal vascular lesion. And what you can see here, this is a dural fistula, and the fistula is located actually along the sphenoid wing, and the drainage is into the sphenoparietal sinus, and then there is a retrograde filling of multiple veins. But more importantly, you can see that there is early filling and arterialization of the superior sagittal sinus. And when you see this, the entire drainage from the brain might be altered. And these are the patients that can present with the picture that is dementia-like type of clinical picture. Now, again, this fistula, I think, also exemplify the concept that it might look quite complex at first, but then once you understand it, it's a rather simple fix. And the reason why this was not treated with endovascular is because, again, we were worried that we would be unable to get very close to the point of fistula, but also we were worried because through some of these external carotid branches with the liquid embolic agent, you can feel some of the dangerous anastomosis to the ophthalmic artery, to the internal carotid artery. And again, the treatment is so simple that there is really no reason to take any risk from an endovascular point of view. So what this is a simple pterional craniotomy. This is the dura, and you can see that the dura, it's involved by these very large feeding arteries. Here is the sylvian fissure, and here is the draining vein. And you can see that the treatment, once you decodify, it's fairly simple. It's, again, a sylvian fissure, dura here, and this is a vein going from the sylvian fissure to the dura and draining into the sphenoparietal sinus. So fairly straightforward treatment, no need to take any risk with other strategies. And here you can see the pre and the post-operative. So once again, the dural fistula with the exclusive retrograde cortical venous drainage might appear quite complex at the first look on the angiogram, but once the pathological anatomy is decodified, the treatment is fairly straightforward and simple, and it consists in occluding the proximal draining vein as it emerges from the dura. You can achieve that with endovascular means in the vast majority of cases, or if endovascular treatment is not as safe as surgery, then it can be achieved with surgical treatment. I will talk about stereotactic radiosurgery later because we do use a lot of stereotactic radiosurgery primarily for transverse sigmoid sinus dural AV fistulas. Don't ask me why, I don't know, but radiosurgery doesn't work well for those fistulas like the ones I've shown, the tentorial, the anterior ethmoidal dural AV fistula, these sphenoparietal fistulas that have exclusive retrograde cortical venous drainage, while radiosurgery works quite well for those transverse sigmoid sinus dural fistula, as well as for some of the indirect carotid cavernous fistulas. Now, this is a different type of, in a way, this is a indirect cavernous sinus slash sphenoparietal dural fistula. But in this case, you can see that there is an excellent transvenous approach. And here is the point of fistula. And through a transvenous route, we were able to get very close to the point of fistula. The varix might be in the region of the cavernous sinus, but then the main drainage is exclusively through the vein of Rosenthal. And you can see that nowadays with the modern endovascular techniques, this is a distal access catheter. It's a Sophia catheter. You can provide extra support with the larger catheter, and that allows you to navigate, as you will see, your microcatheter. This is a large arterialized vein. So you can go in a retrograde fashion and get very close to the point of fistula. And again, our goal is to be as safe as possible. This is it's a relatively straightforward catheterization because the vein is arterialized. So the wall of the vein, it's fairly robust. Of course, you have to be extremely careful. But once you reach very close into you can see here now we are right into the proximal draining vein. And in this case, you will see our choice is to use detachable coils. While detachable coils, because with the detachable coils, you have absolute control. And if you don't like what you are doing, you can withdraw the coils. With the liquid embolic agent, if you start with liquid embolic agent in such a high flow fistula, you might run the risk that the liquid embolic agent might migrate distally, or sometimes it can permeate through retrograde through the feeders and affect the carotid artery. Here you can see now that there is a lot of stasis. What we do in this case is we wait a little bit longer, and then you can see that there is progressive. Once you have occluded the proximal draining vein, there is a slow flow into the main draining vein. Eventually, there is complete thrombosis of the main draining channel, which in turn results in occlusion of the fistula. As I said before, one of the most fascinating aspects of the treatment of dural fistula is that really 95% of the success is related to the strategy, the fact of choosing the right strategy. This is a patient, is a 42-year-old with Down syndrome that was having a progressive gait impairment. And she was noted to have some edema at the craniocervical junction. It was not related to C1-2 instability, which is relatively common in these patients. And this is one of those fistulas like the ones Dr. Ernest Niemi showed earlier on. This is very, very difficult to cure completely because it's a diffuse fistula. There are multiple points of fistula. There is involvement of a major draining sinus, but you can see the external carotid artery in this patient is as big as the internal carotid artery. So here our strategy was, let's see if we can decrease the flow to this fistula as much as possible. We felt we could not safely completely cure it, and see if we can somehow improve her symptoms, thinking that the secondary congestion was related to the massive influx into the venous channels. So you can see here, you can see coils, you can see onyx. We were able to partially occlude the arterialized superior sagittal sinus, but there is still some fistula left. But again, in this patient, our goal was to temporize. Another issue is that this patient is 42, so she has outlived the average life expectancy of patients with Down syndrome. So our goal was to hope that we could improve her symptoms. And sometimes, again, if the strategy is correct, you might succeed. And you can see here that on the 1-year follow-up, now there has been a resolution of the craniocervical junction edema, and she has gone to enjoy a few additional years of life with good quality. Now, we'll switch gear and we'll talk about another subtype is the anterior ethmoidal dural fistulas, very interesting type of fistula. This is a 34-year-old with headaches and early dementia-like symptoms. On the MRI, there is a large cluster of veins, and that raised the suspicion of a fistula, which was confirmed on the angiogram. And you can see typically these fistulas are fed by ethmoidal branches of the ophthalmic artery. The main concern from an endovascular point of view is that, yes, nowadays you can safely navigate the ophthalmic artery and get very close to the point of fistula, but if you use liquid embolic agent, there is a small risk of retrograde reflux and occlusion of the retinal artery with the blindness. Again, this is a young patient. The surgical approach to this is fairly straightforward, and that is usually, even today, it's usually our preference in a large number of these cases, even though, as I said, you can treat it from an endovascular point of view, but there is a small risk. So this is a low-lying frontal midline craniotomy, and you can see the typical appearance of these fistulas with the dural branches converging along the area of the cribriform plate, and you can see that there is a single arterialized draining vein emerging from this cluster of dilated dural branches. So here it's on the ICG fluorescein, and as I said, this is a fairly straightforward surgical treatment. Now, dural AV fistula draining through the anterior portion of the superior sagittal sinus can present with the cognitive decline, which mimic dementia-like syndrome. So, as I said, this can happen and has been reported with the anterior ethmoidal dural AV fistula. We have seen in the sphenoparietal fistula that I showed. So, again, one of the interesting aspects of dural fistula is they can truly present with all kind of different symptoms and signs combinations, because they express alterations of venous drainage that can involve different areas of the brain. And these are two typical examples where there is involvement and arterialization of the superior sagittal sinus, and those are the cases where you might be seeing this early dementia type of syndromes that in the treatment, of course, here it's very gratifying because those are reversible. Now, for the anterior ethmoidal dural AV fistula, it's very, very important to carefully analyze the angiogram and make sure that there is no different drainage from both sides, because bilateral cases, true bilateral cases, have been reported. And it's important to know that at surgery, because you need to expose both sides in order to cure the fistula. Now, again, to bring home the concept that the strategy is key, I mentioned that for anterior dural ethmoidal dural fistulas, surgical treatment might be preferable in several cases because of the risk of unilateral blindness from embolization. But this is a 81-year-old, and as an incidental finding of this anterior ethmoidal dural AV fistula, the question is, should we treat this or not? The patient is otherwise healthy. There is a venous varix. There is a theoretical risk of bleeding. But in this patient, there is also supply from the middle artery. And as I said, the middle artery is usually the friend of the interventionalist because it runs through into the dura, and therefore has a fairly straight course. And in this case, nowadays, we were able, I will show you, we were able to navigate the middle meningeal all the way close to the point of fistulization. You can see the microcatheter getting close. And this is a micro, so here is the microcatheter now. So we were able to go all the way down, close to the point of fistula, and then inject onyx, watching carefully to make sure that in a retrograde fashion, we were not filling the ophthalmic artery. And this is the post-embolization. So again, it's important not to be dogmatic and to use all the options that you have available. And that takes into account not only the different techniques, but also there is no question that it's also highly institutional dependent. In some institutions, they might be more facile with surgery, other institutions more facile with radiosurgery or embolization. Ideally, you should be able to offer in the same place to have available all the different options that you can use interchangeably without being primarily confined or forced into one therapeutic option. This is another case that brings a different message. It's the fact that when we are dealing with fistulas that are close to the brainstem, that's something that at least in our institution, it's something that we are very, very cautious in considering an endovascular option. This is a 32-year-old, progressive headache, nausea, and vomiting over a period of several weeks. You can see on FLAIR, there is signal changes in the brainstem, and this patient has what I would generically define as a craniocervical junction dural AV fistula. You see the large venous varix fed by a branch of the pharyngeal artery, and then there is venous drainage into a spinal vein. You can see the venous drainage into the spinal vein, and you can see how the drainage at the craniocervical junction is affected, and hence the congestion. There is some faint feeling also from a dural branch of the internal carotid artery. As I said, in this case, the pharyngeal artery, we are very, very careful about embolization of the pharyngeal artery with the liquid embolic agents, because it participates to the innervations of the lower cranial nerves. And the other issue is that this fistula, so this is a simple lateral suboccipital craniotomy. This is superior, this is inferior. You can see the entrance of the vertebral artery, and you can see here the accessory nerve, and here is the arterialized vein that emerges from the dura. And then you can follow the arterialized vein along the anterior upper cervical spinal cord as shown by the angiogram. Again, in this case, it's once you understand the anatomy of the fistula, it's a fairly straightforward surgical exposure. And once again, you isolate the arterialized draining vein at the point of emergence. So you can see here that varix that we were seeing on the angiogram, and once is isolated very close to the point of emergence of the dura, then the treatment is pretty straightforward, and it's just a simple ligation of the fistula. And you can do that. You can coagulate and divide. I prefer in such situations where you are in a deep field, I prefer just to put a clip and avoid any coagulation, and seems to be working fine. And here is the post. And you can see, as I said, these cases are extremely gratifying, because this is only after 6 weeks, there is a complete regression of the flare changes with resolution of the clinical symptomatology. Now, the so-called craniocervical junction dural AV fistula, it's important because if the drainage is superior toward the brain, then they can present with hemorrhage, with a known cause of subarachnoid hemorrhage. If the drainage is exclusively inferior, then usually the presentation is with myelopathy, and somehow the spinal veins are fairly resistant to high flow, and the tendency to rupture, it's much, much lower than when you have drainage of these fistulas toward the brain. Now, before I conclude, I'll talk briefly about the most common type of dural fistula, the transverse sigmoid sinus dural fistula, because here at Mayo, we have a little bit of a different approach that we have used over the years. It works very well for us. Doesn't mean that you cannot treat these fistulas in other with other modalities, but 49-year-old disabling bruit typical transverse sigmoid sinus junction dural AV fistula. In this case, the main goal, there is no retrograde cortical venous drainage. So these are not dangerous fistulas. These are fistulas where the main goal is to treat the symptoms. And then, of course, if you can safely close the actual fistula, it's a plus, but it's really not necessary because they're not dangerous. And our treatment plan in these cases, it's actually rather simple, but quite different than many other places. So what we do, we use a transarterial PVA embolization. This is external carotid artery catheterization. It's very simple and straightforward. We use particles that are greater than 150 microns in diameter, and that's critical. Why? Because this way you avoid the risk of going through dangerous anastomosis, because those anastomosis have a caliber that is less than 150 microns. So it's a very simple and very straightforward and safe transarterial embolization. The goal of the embolization is, in this case, to decrease the flow and help the patient with the symptoms. And then we do gamma knife. And the gamma knife, the stereotactic radiosurgery in these cases, it's also very safe if you do it correctly, because you're not radiating brain, you're radiating bone, the sinus, the wall of the, you're radiating the wall of the sinus, which runs into a sulcus, into the bone. So if you plan and dose correctly your gamma knife, your radiosurgery treatment, the risk of any radiation effects on the brain, it's exceedingly low. And this, as I said, is something that we have been doing now for more than 20 years. And this was a landmark publication of one of my colleagues, Dr. Link, who does all our skull-based surgery and also does gamma knife. And you can see the results in these patients are remarkable, because not only you get rid of the fistula, but what's more importantly, with this strategy, you can also preserve the patency of the sinus. As I said, I'm very well aware that in many institutions nowadays, these fistulas are treated with endovascular technique, where you put a balloon to protect the sinus, and then you inject transarterially onyx. But I think that the strategy we use is definitely much simpler and also safer. So what we achieve immediate improvement or resolution of symptoms, and then we have greater than 90% obliteration rate that although we wait 3 years to do our control angiograms, usually these patients, they get an obliteration, complete obliteration within 1 year. And as I said, it's a very low complication rate because you are radiating the sinus, which is inside bone, and the embolization, it's a transarterial particle external carotid artery embolization. The caveat is to use particles that are large enough to avoid the dangerous anastomosis. Now, in patients with transverse, and another practical pearl, in patients with transverse sigmoid sinus dural AV fistula who present with the bruit can always be heard with the stethoscope on the mastoid in every patient. If a patient comes with the bruit and you suspect a fistula, but you cannot hear a bruit, the patient does not have a transverse sigmoid sinus dural fistula. Now, I just briefly go through what has been my experience. I've been involved since I came to Mayo with over 200 patients with 240 dural fistulas. They tend to be elderly, particularly the ones with the transverse sigmoid sinus. Cannot agree more with my dear teacher and friend and mentor, Professor Ernest Niemi, that it's extremely important to follow these patients. You learn a lot. It's not a very easy task, but since likely patients with dural fistulas, there are not so many, and it's one of those areas where I have had a specific interest from the beginning. I really worked very hard with one of my nurses to get as much as possible consistent follow-up, at least for the first few years. You can see the location. The transverse sigmoid sinus is by far the most common. I think this represents an institutional bias. We see a large number of tentorial fistula, but mostly because we are referred a lot of patients that need surgery for this particular type of fistula. And you can see that although the vast majority are treated with a single therapeutic modality, observation remains an important part, especially in the benign transverse sigmoid sinus. But in about 40% of the patients that were treated, we use some kind of combination therapy that more commonly is represented by transarterial embolization plus radiosurgery mostly for the transverse sigmoid sinus dural fistula. And you can see, as Professor Ernest Niemi mentioned in his introduction, there is no question embolization has the premier role nowadays in the treatment of these fistulas. Radiosurgery in our institution, it's particularly used for the transverse sigmoid sinus fistulas without retrograde cortical venous drainage, and we utilize surgery when we feel that these other methodics are not as safe or not effective. The results, we have had no incidents of delayed hemorrhage in the patients that were treated. Symptoms usually improve, or at least they were stabilized in every patient. And this is the most important part that I found fascinating, and is that, yes, of course, there are complications, but again, if you use a very careful and very well thought strategy, and you are very careful. I cannot stress the preparations of these patients, the selection, but also the peri-procedural care and the follow-up. And I don't do the gamma knife, but otherwise I'm involved in every single aspect, because I think that's the key. And I think that concluding, we can say that what is the current state of the art in the treatment of dural AV fistula, and the key is that individualized treatment, either with the single therapy or different combinations, is effective and is associated with low complication rates. And therefore, the goal going forward is that we should be able, with careful and correct utilizations of all the therapeutic options that we have, to reach the goal of zero morbidity and mortality. I remember one paper from one of my teachers at a distance. I never worked with him, but I've always followed and learned a lot from him, Professor Bricolo. I remember very well a paper he wrote, I think it was in 1980, which was on epidural hematomas toward zero morbidity and mortality. And that really stayed in my mind, and I think that's what we should try to achieve, and I think we are very close. Of course, it's a virtually impossible goal, because the only way not to have complication is to do nothing. But again, if we are extremely careful in our thought process, how we use the technique, and sometimes we start with one strategy and then we stop in the middle of a procedure because we realize all of a sudden that the strategy we had chosen is not necessarily as easy or as safe as we originally thought. And always keep in mind that fine balance between safety and the need to treat, and the fact that patients like as much as possible minimal invasive techniques. Once again, thank you so much for this invitation. It's a great pleasure for me to be part of this very successful ground round and to see some of my friends around the world in a virtual format. And once again, I cannot thank enough Professor Ernest Niemi for really serving as an example throughout all these years, and for being a role model and really providing such incredible mentorship. And one of my major professional achievements has been the fact that I'm lucky enough to also be his friend. Thank you very much.
Okay, thank you very much, Dr. Lanzino, for the very wonderful presentations that you bring us, and very well presentations of the collaborations between neurosurgeries and endovascular treatment. And you also tell us like what is the critical points that neurosurgeons or even neurointerventionists should concern. So next point that maybe I would like to invite Dr. Juha, Professor Juha, if you want to say some things to Dr. Lanzino.
Thank you very much, Giuseppe. I think all agree what I said in the introduction, that it is one of the best in selecting analyzing and selecting the treatment. The presentation was exactly that. So it will be the guidelines, I think, for all neurosurgeons and vascular surgeons treating these lesions in the world. So this was very thoughtful presentation, and I learned a lot. I have a long time experience with these lesions. I made mainly microsurgery, but these were different times. So as I mentioned, my series is historical, so now there are new times, and endovascular treatment has taken main part of over. But in some selected cases, it seems that you still need surgery, and this is good to have in mind. So we should go forward with these cases, and as I mentioned, so we diagnose more and more of these cases, especially in China. You have health checks, so you will find a lot of vascular lesions, and many of them are found in these health checks. So we have to assess what to do with these cases, or just to observe the cases. So I think better there is place for more questions or thoughts for treating these lesions, which sometimes look, like Professor Lanzino told, look very complex, but then when analyzing more carefully, then the treatment might be rather simple. So thank you very much for this wonderful presentation.
Thank you very much, Professor Juha. Okay, go on. Yeah, Dr. Ayman.
I think Dr. Goel may have something to say. Dr. Goel, do you have any questions or remarks?
No.
Oh, I'm sorry. Go ahead.
Yeah.
So I have only one remark, that this was a wonderful presentation by my dear friend Giuseppe. And I have been watching his career right from the days when he was a resident, then he became a boy, and then he became a man, and now he has become a legend in the field of vascular surgery. And without any doubt, I have not seen a person more ambitious, more hardworking. You see the number of articles that he has written in 1 year, maybe more than 70 or 80 in very high level journals. And when you write an article, you have a new thought. So here, what we saw today was a combination of thoughts and combination of art of understanding the subject and how you treat an entity after clearly evaluating the radiology and then treating. So I can only say that what Juha had said, that here is a person who is not only a scientist, but he's an artist and a teacher and treats his patients to the best of his ability in a fashion that is top level in the world. So I congratulate you, Giuseppe, for this wonderful, wonderful presentation. There is no question, I will always remain proud of my friendship with you, Giuseppe.
Thank you. It's Atul, it's always a great pleasure to see you. I've learned a lot, and you know, it's I know the high complexity of the cases that you treat. In a way, I'm lucky because it's a lot of the cases that I've shown somehow they are diagnosed very early on, and so they are not quite complex. But I've seen your cases, and so it's always a pleasure to see you, and very proud to be your friend.
Thank you, Giuseppe. Thank you.
I think Dr. Ayman Ali Mayas, he raised his hand as he wanted to ask questions or comment. Please, Dr. Ayman.
Yes, please. Can I ask a question, please?
Could you raise your voice a little bit?
Yes, can I ask a question for the professor? Thank you very much, professor, for this wonderful lectures. My question, please, about the neuroimaging for the dural IV fistula. I mean, when you order, I mean that dural IV fistula is difficult to visualize by routine CT angio or MRI. Are you go directly to catheter angiogram? What is the most suspicion to go for catheter, or you order before CT angio or MRI angio? And the second question, please, you mentioned that dural IV fistula come with dementia. Is it now routinely to do neurovascular imaging for patients who present with dementia or not? Thank you.
Yeah, usually patients have when there is a clinical suspicion, we if we suspect a fistula nowadays, we start with MRI, and we do a time resolved MRI. It's a TRIX protocol, or you can use the PC Fiesta, that is the same sequence that they use for to identify neurovascular conflicts in patients with trigeminal neuralgia. But if the clinical, I agree with you, on the CT, on the MRI, it's not that straightforward to identify a fistula, especially if a small one is present. And if the clinical suspicion is strong enough, we go to catheter angiography. But nowadays, the vast majority you kind of suspect based on the combination of clinical symptoms and usually indirect radiological findings on CTA or MRA, even though I must say some of the specialized MRA sequences are getting really good in diagnosing the fistula, as well as some of the CT angiograms. As far as your question for the dementia, it's of course the fistulas are relatively rare. while dementia is particularly common, especially in the elderly population. So I would not advocate an imaging studies in every patient who is diagnosed with the progressive cognitive decline, but I would definitely suggest in patients where some of the findings are a little bit unusual. For example, a patient in particularly young age group, or if there is coexistence of other components on the clinical presentations that might be a little bit unusual. Otherwise, it would be impractical to do neurovascular imaging in everybody with cognitive decline.
Thank you, Professor.
Okay. Stop. Okay.
Good morning, Dr. Lanzino. Brita, I hope you remembered me when I had a visit to you.
Yes.
And,
Yes.
thank you, Professor, for the great, actually, and short experience. It's always extraordinary for you to have these complicated cases managed very well. First, my questions, Professor Lanzino, regarding that the embolization for the EP and for the fistulas. Would you always combine the gamma knife and the radiosurgery with embolization, or you just can make the gamma knife without embolization?
Yeah, very, very important question. No, if a patient, the embolization in those patients, it's primarily because of course the gamma knife, there is a lag period between the treatment and the effect. So if a patient has a bruit and does not have, but it's not disabling, then we would definitely we would avoid embolization. In other cases, if the patient has only a bruit and we try the embolization first and consider the gamma knife only if there is recurrence. You were here with us for quite some time, so you know that we try as much as possible to stress safety, and then after safety, try as much as possible to come up with the simplest solution to a problem. So in those cases where there is no concern about retrograde cortical venous drainage, then as I said, occluding the fistula completely, it's a plus, but it's not really absolutely necessary. So we would titrate that to the symptoms. And if the symptoms are not disabling, consider gamma knife alone with bypassing the embolization.
Okay, clear enough, Dr. Lanzino. Thank you. I was happy to see you again. Thank you.
Hey, good to see you.
Hi, Giuseppe. Thank you for your nice presentation. And then most of my strategy is same as your strategies, but I didn't try the PVA particles injection for the transverse sigmoid DAFVs. So what kind of this subtypes of this DAVF? Because sometimes there are some high flow fistula, you should maybe embolize it with onyx at first, then some small left remnants you can inject the PVA.
Yeah, you know, like our strategy, it's based on the fact that in those fistulas, we don't try to cure them with the embolization alone. So, and because the goal is, number one, if they have a disabling bruit, is to improve the bruit, and you can achieve that by decreasing the flow. Now, there is no question that the PVA is not a permanent agent, and with PVA, you do not cure the fistula. you can help the symptoms and you can decrease the flow. And that's one of the main reasons why when we do that, we usually, although not always, but we usually follow with the gamma knife. Now, there are instances, as I said, nowadays a transverse sigmoid sinus fistula can be fairly safely treated with transarterial onyx embolization, while with the balloon you protect the sinus. And the treatment is always in evolution. Traditionally, we have been doing radiosurgery for that specific. If the patient does not have dangerous features and the symptoms, it does not need a cure. For that specific type, transverse sigmoid sinus, some of the CC fistulas. As I said, I don't know why, but my impression is that radiosurgery does not work for the tentorial, the anterior ethmoidal, those fistulas that have an exclusive retrograde cortical venous drainage. But and that's the reason why we use PVA in those patients, because again, we are not trying to close the fistula, we are trying to improve the symptoms, and therefore, in our hands, is definitely the safest and quickest way to achieve that. And cheaper too, which is becoming more and more important.
So actually, in your presentation, you mentioned there's 1.7% of the mortality. Is it correct?
Mortality, we had in the entire series, we had 3 deaths. So it was 1.8. And 1 patient died because there was a consequence of mostly of the hemorrhage, was an elderly lady. And in 2 patients, the deaths were directly related to the treatment.
Okay. Is there any possible that sometimes you occluded the fistula, high flow fistula, then there's would be cause some thrombosis in the venous side?
Yes, there is definitely that risk. So what we do in those situations, when we do the final angiograms and we have completely occluded the fistula, and we see that there is very slow flow into large veins, quite often we keep those patients at least overnight on some form of low-grade anticoagulation, and then usually we transition to aspirin, but we keep them on anticoagulation for a day or 2 in the intensive care unit. We'll make sure they are well hydrated. And I'm very, very well aware that there is that possibility. Now, likely I have not seen that, but again, as you saw, the cases that we have treated are complex, but the ones that they are incredibly high flow, those are likely not that common for us.
Okay, so what kind of medicine you would use? The heparin or
we use heparin. Heparin,
okay.
but there are 2 protocols that we use, and we use the lower intensity so that you can maintain an IV dose of heparin without getting the patient too anticoagulated.
Okay, thank you.
Hey, Warlocks. Any more questions?
Another question
comments?
for Giuseppe. So you mentioned the anterior cranial fossa DAVF, you would use open surgery. So what kind of incision you would choose? The bifrontal big incision or small or some small incision?
I usually do similar to what Professor Nestiemi does. It's a sort of modified lateral supraorbital. I just extend the craniotomy a little bit more medial, because the issue is that I've tried to do through some minimal invasive, but the problem is that you can do it, but you have to be very careful in those cases not to mobilize too much the frontal pole before you actually have access to the midline. So I tend to do a standard incision and, you know, sometimes extend the incision a little bit across the midline so that I can mobilize the skin all the way down and have direct exposure of the, I'm sure you can, you know, potentially do the same through an ciliar incision. But again, in those cases, I'm always worried about the fact that you know, you don't want to mobilize too much, and I like to have a little bit more visualization of the surroundings that you might achieve with the true, you know, minimal invasive approach. But as I said, there are different ways of doing the same thing. That's the way I feel more comfortable. And I know that when I try to minimize my access, I realized that I was making a fairly straightforward, simple procedure a little bit not more difficult, just to try to minimize the opening, and I didn't think it was worth.
Okay. Normally, I will use a bifrontal approach. It can expose the.
Yeah, you get a very good exposure all the way to the anterior cranial fossa. Absolutely.
Amazing lecture, Dr. Lanzino, and very useful for all of us.
Thank you, Victor.
Thank you. Hello, Dr. Atul Gol. Nice to see you.
Victor, always, you know, I'm trying to follow your hairstyle, and I'm slowly and surely coming closer to you. Binzu, you will take a lot of time to come close. But nice to see you, Victor.
Nice to see you too.
And
nice to see you, Atul. Go on.
Okay, any more closing comments or questions for Juha or Dr. Lanzino? Well, I'd like to thank you very much. Oh, go ahead. I'm sorry. Go ahead, Ben.
How many?
Professor Lanzino is a hybrid neurosurgeon, and he is always have some new ideas that we can learn from him. Especially most of my work is similar to his work, so we are good friends. And today I learned some PVA injection combined with a gamma knife. I will try it. Thank you. Yeah, Professor Juha.
So how many observers? How many audience?
Oh, okay, let me check. It's already well, it's around 2,500.
Very good.
Okay, tomorrow.
Yeah.
Will increase tomorrow.
Oh, very good.
Yeah.
Okay.
So next week we will meet.
Professor Lanzino, we are translating your presentation into Chinese and broadcast to the WeChat channel. So today the audience number is 2,500.
I've heard it's incredible. Incredible.
That's great.
Usually increases with 1,000.
Big star in China
during the weekend.
Okay, very good. I'd like to thank everybody. Any closing comments from anybody?
Professor Lanzino.
Same time. Next week, same time on AVMs, yes?
AVMs?
AVMs next week, same time.
Okay,
Yeah.
great.
Can I?
Okay, we'll see everyone next week. And hang around after, because this is a good way to network. And if you can stay around, Dr. Lanzino, if you can, for a few minutes, and
Sure, absolutely.
Dr. Goel, just to meet some people. And now I'm going to close this formally. So thank you.
Thank you very much.
Okay,
Thank
but
you.
it's just,
Thank you.